complete that and send you pictures? How do you want submission to happen?
No. So basically, what you have to do, so you look at the clip, right, where the Titanic ship starts to sink and the whole involvement of the events, correct?
Yeah.
So I just want everybody to look at that clip and understand or try to find out what was the couple of things that went wrong that led for the boat to sink the way it did, and then you would complete the fishbone diagram, where you would basically add what were the factors that led to the whole event. So you know the video that Akram showed earlier, right? So there was a lot of events that led into the result, right, of that lady being harmed. So that was the same thing on the Titanic example. I just want everybody to look at that clip and look at it to try to find out, okay, this went wrong, this wasn't notified, this was missed of information, and then complete the fishbone diagram according to that. Does it make sense?
Yeah, and how do you want that to be submitted to you?
Oh, just you can, either right-handed and send it, with a picture, or you can just type it. If you want to draw the fishbone again and then type it on on the computer and then send it. It's fine either way.
So you want it to be emailed to Shadia?
Yes, you can either email, or you can email it to either you can email it to Rakan and NCC Shadia, or email Shadia NCC to Rakan. It's fine.
All right. Okay, that's clear. Thank you.
Okay.
So
let me take it from there.
Let me just explain it to everybody. आपको क्लियर हो गया जब वो जो प्रोग्राम आई है उसको बेसिकली आप प्रिंट आउट निकाल के हाथ से उसको आप लोग भर लें, उसकी आप खींचें तस्वीर और वो तस्वीर हमारा जो तायरा को भेजते जाए, वो सारी मैं कलेक्ट करके मैं वहाँ उनको भिजवा दूंगा, ग्रुप में अपलोड कर दें। नहीं, नाम लिखना है आपने, हर आदमी ने अपना मसला ये है कि फिर उनके पास 26-30 ईमेलें चली जाएंगी।
Hussein, can you hear me?
Yes. Yes, Sophia, we can hear you.
Okay, so I can start, yeah?
Sorry?
Can I start?
Yeah, sure. You can start it.
Wonderful. Okay, let's do this because we have a very short time now to wrap up this morning. So let me just again share with you my screen, And again, I apologize from now if it feels a bit rushed. It's just that we're very mindful of everyone's time. So let's just get started. And I will, where is it? This one, okay. I'm just gonna put this on full screen. Can you hear me? Can you hear me?
Yeah, we can hear
Okay,
you.
wonderful. Okay, thank you. I'll just move on then.
Okay.
Okay, so what we will speak about in the next half an hour, hopefully, it's about workforce safety. And as we all are aware, it's this year's main theme for the celebration of the World Patients Safety Day. And it's about basically that there will be no patient safety without workforce safety first. So before we get kicked with the presentation, I just want to show you a video that will set the stage for why is that so important that we speak about workforce safety, okay? Just 1 second. I'm going to change the screens so I'm able to show you the video, okay? And even if you can't hear it, the video it's kind of a bad quality, I have to be honest, but it's something that happened in the Middle East, and even if you can't hear it, it's fine. It's a CCTV video, so the quality isn't amazing, but just try to pay attention to what's happening in the video, okay? Let me just show you. Okay. Okay, so as you can see there is this gentleman coming towards the nurse station, and now he goes over and just see what's happening. So basically he stabbed the nurse's arm. Okay, so this was just a very short video. It might, it might not be something that we like to see, right? But let me just change my screen now. Okay. So as you could see, and again, I know it might sound a bit like too much, the video that I showed you, but this is really to set the stage on why is it so important that we speak about workforce safety. When I started teaching this a while ago, I used to say that this theme, the workforce safety, it's an elephant in the room. And an elephant in the room, it's an expression we use whenever we know that there is an issue, but we don't like to talk about it. And there might be many reasons why we don't like to talk about it, because, it might be because we would rather think that it doesn't happen or doesn't exist, it's not an issue, or we do know there's an issue, but we don't have a way to fix it, so we don't even want to talk about it. So unfortunately and unfortunately at the same time, as I said yesterday, COVID and the pandemic kind of brought this to light. And it's not just about staff getting infected, it's about staff getting physically harmed, emotionally abused. So there are a few, I don't want to say good things that the pandemic brought us, but it definitely brought us some light into what before was an elephant in the room. I guess now everybody, it's more, let's say, keen on talking about it. So at the end of the session, what I want to go quickly with you is to discuss the current issues on workforce safety, describe the association between workforce safety and patient safety, and why is that WHO decided to nominate this theme for this year. Why is that so important? Identify recommendations to improve workforce safety and review examples and successful practices to promote workforce safety in your institution. Now, why am I showing you this picture? So this is just two examples of models that support patient safety. So, within different organizations, people adopt different frameworks, different pictures that reflect how do they value patient safety. Nevertheless, and regardless the model we choose for our institution, there's always one thing that it's always there, that you will see in every model, regardless which one you choose for your institution. And so here, the one that says a framework for safe, reliable, and effective care, you will see on the orange side that you have something called psychological safety, right? So basically, it's really about, in this model, they do consider that in order for you to achieve patient safety in an institution, as part of your culture, you have to have psychological safety. And on the other one, on the 6 domains for culture of safety, the other model, you also have, it's also orange, but just by coincidence, that hexagonal there, that it says trust, respect, and inclusion. So it also brings us back to safety of the workforce, regardless at which level. Now, let me just give you some history behind the movement around workforce safety. Though this is not something from today. It's not something that just started to be looked at in 2020 because of COVID. This has been looked at since many years. And again, I'll bring you back the same gentleman that I mentioned yesterday, and Anita also has mentioned, Dr. Lucian Leap, and what his institute does in regards to promote workforce safety. So in 2013, the National Patient Safety Foundation's Lucian Leap Institute, they published a report that it's called, as you can see in the slide, it's called Through the Eyes of the Workforce, Creating Joy, Meaning, and Safer Healthcare. And the report basically, what it gives us, it gives us research on workforce safety, including physical and emotional safety, gives us an overview of challenges associated with workforce safety and recommendations for workforce safety and case studies, okay? And examples of organizations who have somehow demonstrated their commitment to patient safety. Now, I decided to share this with you. I know it's an old statistical graph, but somehow, it's really still up to date. And basically, what I'm trying to show here, it's the graph on the left side of the screen, right, represents the data from the US Bureau of Labor Statistics. And as you can see, from the red line on the graph, the causes of physical harm in the US hospitals have consistently exceeded the average rates of harm across the private industry in the US. And the graph on the right side of the screen also shows that healthcare industry, which is represented in red, it's one that is actually the most dangerous and harmful than other industries, than those that are usually reported as dangerous. And I touched base on this yesterday, that healthcare actually it's more dangerous than any other private industry that you may think, like construction and manufacturing and mining and all that. We know that physical harm is a common occurrence in the healthcare industry. And this is something that is related to our profession. And in fact, our healthcare workforce experiences injury rates that are 30% higher than other industries. And a majority of nurses, for example, they indicate that unsafe working conditions can interfere with the delivery of quality care. And in major metropolitan areas, a nurse or a physician has 5 to 6 times higher chance of being assaulted than a cab driver in the same urban area. And we can see that, and the video was a clear example of that. Now, what is it that we get more harmed on? Healthcare safety. So this is just a graph before I move on that I wanted to show you what I was telling you. Where does nursing and healthcare industry sits in consideration to other industries. So what is that we get harmed about? And as you can see, the top 5 causes of injury among hospital workers are, so you have overexertion and bodily reaction, you have slips, trips, and falls, you have contact with objects, you have violence, you have exposure to substances, and you have other causes as well. So, I mean, as many of you are well aware, violence is increasingly a common cause of harm. And this includes violence to our workforce from whoever enters the hospital, really, from patients, from visitors, anyone that can actually have access. And sometimes, it can actually go beyond and be between colleagues as well. And while the data that I've just shared represents reports of injuries within the US, I'm sure you would find similar reports within your country also. This is just some examples of what goes into the news regarding the impact of violence, let it be physical or emotional, into our healthcare workforce. And again, this is a bit old, but somehow you will find similar headings and headlines because of the current pandemic. Fatigue is definitely one of the most common harmful events to our staff, and as much as we try to look or to make it normal, not normal, but people say I'm tired, I'm super tired, and we don't really take it serious. We think that it's just something that we have to learn to live with our profession. However, fatigue results in the impaired function, resulting from physical labor and mental exertion, as we know. And there is a clear evidence, and this is what it's very important that we are aware, especially those of you that are managers and you have to deal with staff and with working shifts and so on. This is very, very important you bear in mind that the evidence associates fatigue with extended working hours, with greater harm to patients and to our workforce across all professions in healthcare. As one example, and probably the lot of examples we have, it's on nursing, and perhaps because nursing, it's the biggest healthcare workforce, let's say, slice, and they might, perhaps because there's a lot of research conducted in this profession, and this is why. But I can assure you that this goes beyond nursing. But as an example, a nurse who works for more than 12.5 hours has 2 to 3 times greater likelihood of making a medication error. Yet longer work shifts, such as 12-hour shifts for nursing, provide many benefits that can also provide joy and meaning to our colleagues. So this is where you have to find the balance. A lot of nurses, they do prefer the 12-hour shift, but we also have to be aware of the consequences of going beyond that. Okay. So it's quite common that we speak about physical harm, and whenever we think about harm, we think about physical. But we have to be very mindful of the other type of harm that it is not so obvious, but it can be more, I would say, harmful than the physical harm. And because it is more harmful because it sits there for longer, and by the time you realize what's happening, it's probably too late, and it's probably having, you know, consequences that are difficult to repair, to either both the healthcare professional and the patients if they actually got harmed because of that. You know, fundamentally, you know, in our cultures, in many cases this is functional, and the root causes for this is the, you know, the lack of respect. And you know, Anita has touched base on it, and it will probably touch base on this a bit more. So this is very important that we, you know, we look into this within a more serious way, and not just as something that we have to live on with. And usually, you know, within physical psychological harm, we divide into the lack of the 3 R's. So respect, recognition, and resources. So if there is lack of respect, if there is lack of recognition and lack of resources, you can bet that your staff will be developing some sort of psychological harm. Lack of support, lack of appreciation, or non-value add work, production pressures, scheduling demands and fatigue, poor design of work environments and workflows, ineffective communication and conflict resolution. You've seen situations where just the way a hospital or a unit is designed that can affect immensely, you know, how tired or how effective your staff can be when they perform. So this is also, you know, it's very important. Then sometimes, you know, when you have to redo a new unit or you are building a new unit, many, you know, some staff, they're like, you know, why do I have to sit on those meetings? You know, I'm not a construction person, I'm not an architect or this or that. Believe me that whenever there is a redesigning on the unit, or there is some changes on the way, you know, on the layout, the physical layout of units, you know, nurses and physicians and health, those that work there, they should sit at the table to make decisions, because this really impacts, you know, the level of fatigue that we get. Now, a culture, you know, and again, I'm not going to go deeply into this because Anita will touch it, but when this disrespectful behavior occurs, it must be addressed consistently and transparently. It must establish unequivocally the expectation that everyone is entitled to be treated with courtesy, honesty, respect, and dignity, regardless their job title and their profession. The code must be enforced fairly through a clear and explicit process and applied consistently, regardless the rank or station. Why do we need to change? You know, where is the evidence to change? Now, whenever you need evidence to change something, you know, it's easy to apply a survey to find out what's your baseline, you know, then just to assume that things are not right. And you would be probably surprised if you do apply 1 or 2 surveys that aim to measure the level of, you know, fatigue or how does your staff feel respected or not. And Anas has mentioned earlier about the patient safety culture survey. And if you do apply it in your institutions, you will have a sense there are some dimensions throughout that survey that they capture the perception of your staff in regards to how respected they feel within their institution. So, you know, and you will have evidence that will support the need for change. Some of this example is physicians, for example, in a given survey in 2013, they said that, you know, 60% of them are considering leaving the practice, 70% know at least one physician who left practice due to poor morale, and 1/3 report severe emotional exhaustion. Within nurses, we can find the same trend, and you know, when it comes to leadership, few CEOs have taken up the challenge to transform their organizations, and this is because they don't really understand why they have to. One other dimension that is very important to consider, and it's been spoken about immensely this year, is about burnout, and you know, how burnout is important, and we shouldn't discard it. It has to be looked at very, very seriously, and the why seriously, because the impact, the negative impact that it has on patients and workforce, it's very, very important to be tackled. And I'm just giving you this example, that the Maslach burnout inventory, it's a worldwide known, and perhaps you've heard about this before, has been validated multiple times, has been validated in many different languages. And it's a ready to use tool that you can just take it and apply it in your institution, and it would give you a sense of how does your staff feel in regards to their own burnout level, if they have any, and I'm sure they will, and how serious is it. And if you do find results that are concerning, this needs to be tackled as soon as possible. Now, and why we need to tackle this as soon as possible? So the costs of not doing anything, this is what's going to happen. So you with burnout, you have lost work hours, you have high turnover, you have inability to attract new people to the caring professions like nursing, like medicine and other professions within healthcare. You have less vigilance regarding safety practices for both patients and the workforce. Definitely, you have an increased room for medical errors and harm, and obviously the impact on patient experience. I mean, put yourself on a patient position and wonder, who wants to be looked after by a nurse or a physician that is stressed out, that is tired, and has no time and no energy to look after you. One of the biggest impacts of burnout, it's something that we call within nursing called missed nursing care, or called miscare. So missed nursing care is related to essential. Okay, and this happens, and there was a report in around 402 NICU nurses, and 50% of the hospitals that were given the survey, they were magnet hospitals, and they report 52% reported missing at least one, and a median of 5 normal nursing care activities during the last shift. So what this tells you, that half of your nursing staff, whenever they go home, they have probably missed doing at least one, and an average, a median of 5 activities that should have been done. And all this because of burnout. And studies also reveal a correlation between teamwork and missed nursing care. So the more teamwork you have, the least missed nursing care you also have. And the inability to provide expected care diminishes the joy and meaning of work. Obviously, I mean, if you go home knowing that you missed some level of care to your patient, you won't feel good about yourself. And what is the price tag of workforce harm? I mean, you are, let's say, a CEO of an institution. You deal with the financial piece, and how much is this affecting your institution, right? I mean, how much are you paying for this? How much are we all paying for this? So it's if you think about the consequences of burnout, for example, or any workforce harm, right? If you think about the consequences of that, whenever the staff, they have to, the loss of productivity, the loss of lives, right? If it's patient harm, and if the patient ends up dying, or if the patient ends up having to go through treatment, I mean, it goes up to trillions of dollars every year for whenever, related to patient harm. And now you add on what happens to the healthcare professional. Maybe, they are too stressed out, or they are physically injured and they can't go to work. So, so they're not producing. However, you're still paying for to cover for the treatment of your staff, and so on. I mean, it's a cascade, you just name it. Okay, now let me just tell you about something that it can be quite serious, adding into the burnout, which is something you can't see. To really see if this is happening or not, and if this very harmful or more harmful than not having your staff at all in your unit. So it's something called presenteeism. And presenteeism is a condition where you are at work, but you're not there. And when this happens, it's, you are at work. So, you have a staff that came to work, but they're not producing. And more seriously than that, not just that they're not producing, it's that they may be causing harm because they're not emotionally at the hospital or working. And it's a major contributor to loss of, as I said, a loss of productivity. It's a condition in which employees are unable to give 100% of their focus and effort in their jobs, and when they're actually at their place of work. When employees show up, but they aren't there, and highly prevalent in organizations that have employees who are depressed and suffering from anxiety. So, and you as a manager, if you see this, if you feel that you have staff in these conditions, please address it as soon as possible, before these staff they can harm patients, not because they want to, but just because they're not, psychologically they're not well, and they can cause harm. So what is the logical cascade around this? So safe care requires safe delivery systems. We've mentioned it yesterday. So it's not just about the person, it's about the system where we work in. Cultural freedom from harm and disrespect is essential. It's a precondition for people to feel safe to practice within your institution. Preconditions allow employees to habitually pursue learning, and they engage in continuous learning, and this fulfills them into their own career, and this brings them to make them feel good about the work that they provide, about the care that they provide, and they find meaning for their work, and this somehow makes them go beyond what is meant to be their, what I should be doing, and this drives into better patient and overall healthcare outcomes. Now, what I'm going to show you now, it's around 7 organizational imperatives that an institution needs to have, and I'm going to rush a bit now, that they need to have to make sure that their staff are safe. So institutions, they have to develop and embody shared core values. Again, everybody has to be speaking the same language. Everybody has to understand that's respect, transparency, truth-telling. It is one of the most important values within your institution. Adopt the explicit aim that eliminating harm for patients and workforce, it's your aim, your main value of your institution. So workforce, they feel safe to work there. They have to commit to creating a high reliability seeking organization. And we touched base a bit on that yesterday. Institutions have to create a learning and improvement system. They have to establish, let's say, softwares or tools that capture data, and they can measure performance for accountability and improvement, that it's transparent for everybody. Recognize and celebrate the work and accomplishments of the workforce, and support industry-wide research to design and conduct studies that will explore conditions in healthcare that are harming professionals and patients. Now, what we aim with this, it's the perfect alignment of what I call the alignment of safeties. So we need to perfectly align the workforce safety with patient safety. We cannot have an imbalance here. And this alignment can be beautifully seen on a graph that was exposed by an institution in 2013. And this is the kind of graphs you should be aiming for in your institution. So this is how it should look like. It's an old graph, but something that I feel that every institution should aim for this. So if you look here on the red graph, it shows the number of injuries or illnesses reported by healthcare professionals, okay, from 2009 to 2011. And the blue graph, it's the number of serious safety events throughout the same timeline, 2009, 2011. So what can we see here? The same trend, that as the injuries get reported less and less, you will have also less and less reported serious adverse events within your institution. And this is so clear that if you have safe staff, you have safe patients. And this is one of the most important points I would like you to bring with, to take with you today. The Free from Harm report was a report that was also conducted or released in 2013, and it kind of gave us some recommendations. And I'm just going to go through the 8 recommendations, and then later you can have a better look at them. But first, it's to ensure that leaders establish and sustain a safety culture. They create centralized and coordinated oversight of patient safety. They create a common set of safety metrics that can reflect meaningful outcomes. They can increase funding for research in patient safety and implementation science. They should address safety across the entire care continuum. They should support the healthcare workforce, and this is the most important recommendation I want you to focus, and partner with patients and families for the safest care and ensure the technology is safe and optimized to improve patient safety. What should we do as leaders? What should you do as leaders? Or what should your leaders do if you are a patient safety officer? So ensure that you have an agenda item at all board meetings around patient and workforce safety. How many of us actually go to meetings or boardroom meetings where you have the first slide you see, it's the metrics of how this workforce safety looks like today at my institution? Have we ever seen one of those scoreboards? Perhaps not. This is something that it should be on the agenda every day. Mandate full accountability for reporting and eliminating workforce safety across the organization. Require the use of workforce safety dashboards, as I mentioned, understand the rates and what types of harm are we having in our institution. Encourage real-time, internal and publicly, transparent reports of workforce safety. Include discussions about workforce safety in daily patient huddle briefings, and engage occupational health, human resources, and organizational development in workforce team members. Develop committees that proactively address known and suspected sources of hazards. Ensure that meaningful programs and incentives are in place for worker engagement. Add workforce safety stories at board and leadership meetings, and invest in technologies and resources that ensure the safety of your staff. One example, I don't know if you have this practice within your institutions, but this is something that started to be very common and popular in Saudi, and some hospitals have been doing this for many years now. It's what we call the safety huddles. So the safety huddles, they promote safety not just for patients but also for the workforce. It's basically a moment within the shift. It can be at the beginning of the shift. Some units, they do it halfway through the shift. Some units do it 3 times throughout the shift, where everybody gathers and they huddle to try to understand what are the major concerns that involves patients and also the workforce. Paul O'Neill's used he developed 3 key questions that every person in one hospital should be able to answer yes every day. So what I advise you to do is take those 3 questions and ask your staff to answer these 3 questions. And if they answer yes to all of them, fine. If not, then something needs to be looked at. And the first question, they sound very simple, but they're very important. Am I treated with dignity and respect every day? Do I have the things I need to work, education, tools, financial support? And am I recognized and thanked for what I do? It sounds quite simple, but they can actually have a big impact when it comes to the psychological well-being of your staff. I can share something with you. I'm from Portugal originally, and before I moved into Saudi, I worked in the UK, and before that I had worked in Portugal. And I remember that when I moved from Portugal to the UK, I was astonished by one little thing that my team leader asked me after my first shift at work that no one has ever asked me before. So my background is cardiac surgery, ICU, and there I was, first shift in a foreign country, trying to do my best. And at the end of the shift, my team leader comes to me and he asks me, he tells me, and this is what shocked me the most. He said, "Thank you for what you did today." And I was like, what? I couldn't believe it. Like, and then he wasn't just thanking me. He took, and this was practice. He went one nurse to another nurse, telling them, "Are you happy with everything today? Thank you for what you've done today." And to me, there was such it made me such a massive difference. Something as simple as, "Thank you for what you did today. Are you happy with everything today?" Okay, so this really makes it a big difference, and it's very, very simple. And usually, ways to address psychological safety, it's with simple approaches, nothing very fancy or even expensive. So ask yourself those questions before we finish. Do you know your organization's rate of injury and the costs associated to it? Do you know your occupational health or environmental safety and human resource leaders? Do you know who they are? Do you meet with them in a regular basis? Does your leadership meet with them on a routine basis? And have you ever created collaborative reports with these teams? Does your leadership understand that workforce safety is a precondition for patient safety? Is workforce safety addressed in your strategic planning? Or even in the goals of your institution? Again, we can't build a castle with good foundations. And if your castle is your patient safety, your foundation is your workforce safety. Does your organization has a workforce safety dashboard? What's on it? Who sees this? Are your workforce injuries publicly posted? Is your data ready to be accessed all the time? So there's questions you can ask yourself that can help you realize how good or not good you're doing in your institution. Now, just before we finish, and the final note on this. So this is a graph, and this is an exercise like we did yesterday. So this graph represents an overall number of infections by COVID-19. And this piece of this pie, the red part, represents, and if we were in a workshop, I would take you the time to do that, but I'll just go ahead and do it. The red slice represents the number of healthcare professionals infected by COVID-19. Now, let me give you some numbers that puts things into perspective, and why is this so important? So today, we have around 22 million people that have been infected by COVID-19, okay? And back in June, the International Council of Nurses, they've realized that around 6% of the overall number were cases among healthcare professionals. Now, if this is a true number, and if we extrapolate that 6% for today's number, so if we have 22 million people infected with COVID-19 today, and we take 6% out of that overall number, we have over 1.3 million healthcare professionals infected today by COVID-19. What is happening to these healthcare professionals? They're probably, can they practice? Probably they can't. They're home. So who's covering for them? Who's looking after patients? So this to tell you that by not protecting our staff, we are putting our patients in danger. So this is very, very important to be considered. So basically, we have an initiative in Saudi called Safe Staff Saves Lives. And Harry Ford in 1923 from the automobile industry used to say, chop your own wood and it will warm you twice. What's the meaning of this? That take care of your employees, they will remain loyal and deliver great customer experiences that is reflected in safe provision of care. So, if you look after your staff will look after your patients. And this is basically the message for today. And feel free to, put any questions, to email, to get in touch with us if you would like to have, better understanding around this. Way better.
Thank you, Sophia.
Thank you, my dear. Are there any questions? Otherwise, we can move into Anita's presentation, and then maybe we can leave the questions towards the end for the sake of your time and ours.
Yes.
We don't have any questions. I think we can move to another
Okay,
section.
wonderful. Go ahead.
I think we for Anita.
Sorry, can you repeat that? I didn't understand.
Yes.
Hello?
Hello.
So,
Yeah, I was just saying the message was
so
clear. The workforce safety piece is very, very important. So if there is any questions,
No, we don't have any question. And thank you so much, Sophia. And I think another session by Miss Anita.
sure. Anita, you can go ahead, dear. Anita? Anita, can you hear us?
can you hear me?
Yes, we can. You can go ahead if you're ready.
Good morning, everybody. Welcome back. I'm going to, again, it's Anita Moore, and I'm here at the Patient Safety Center, and we're going to, the next lecture is on pursuing a culture of safety and respect. So the objectives are to identify a range of behaviors that undermine a culture of safety and respect, describe the relationship between behaviors that undermine a culture of safety and respect, and the outcomes, and articulate the essential elements of an organization, infrastructure, to address some of these elements. So I'm just going to start off with an example, a case scenario. The following event was reported through an event reporting system. Doctor surgeon was scheduled to perform a procedure on a 72-year-old patient. In the OR, the team attempted to perform a timeout, verification of patient identification, correct site and procedure. That's what they had wanted to do. The doctor's surgeon responded, "Let's get going. We are all on the same page here." So when this happens in a clinical situation, how does it make people feel? Let's get going. Would people feel there's a threat to their safety? Is it a marker of being lack of respect? Is it a behavior that undermines a culture of safety and respect? So think about those questions as we go through the presentation. We are all, as professionals, have professionalism, and we are all self-regulated. Professionalisms are willing to engage in all aspects of the job, whether it's tedious or otherwise, to the best of our ability. Professionals commit to technical and cognitive competencies and clear and effective communication, being available, modeling respect, and self-awareness. Professionalism demands self and group regulation, right? And we have a code of ethics as professionals that we follow, which is really important. To do something requires more than a commitment to professionalism and personal courage. It requires a plan, people, process, and systems. To create an atmosphere of safety and an atmosphere of respect, and you've probably seen a lot of the videos that you saw earlier about how people were speaking in the OR, the video on what Ines talked about on the survey, patient safety culture survey. All those are elements of trust and have elements of respect in them. And it's throughout creating a culture of respect. It's not always that simple. It requires a dedicated organizational infrastructure, understanding and processes and systems in place to do it. And I'll share with you some of those. It requires elements that promote reliability. And people, that's your teams, your team membership, your committed leadership, your project champs, and implementation teams. You need processes. You need a clear vision, goals, policies, and procedures, and sufficient resources and tiered intervention models. Those are your professionals. And then you need your systems. You need your policies, you need your tools, you need your metrics, and you need a reliable review of that process and training. Those are the key infrastructure elements that you require no matter what policies or what that you're putting in place. These are the elements that are always required for us to move forward. So what are some of the behaviors that you see that undermine a culture of safety? You probably see them every day in your work, unfortunately. They interfere with your ability to achieve intended outcomes. They sometimes create intimidating, hostile, offensive, unsafe work environments. They threaten your safety and they violate policies, right? They're including conflicts of interest and compliance, and it could be aggressive or violent or physical action. So these are the kinds of behaviors that you find that undermine respect, trust, and don't create a culture of safety. But we have surveillance tools. You know what surveillance tools are. So for creating a culture of safety and respect in our workplaces, one of the key tools is, say, staff concerns. When you hear about staff concerns, when you hear people saying, well, you know, this is what happened in the OR, I felt really I didn't feel good about when that occurred. Sometimes people have that passive aggressive behavior, you know, they say one thing but do another, it's very subtle. All those kinds of things and behaviors result in culture of not being respectful. So staff concerns are really important when we're talking about culture of safety and respect. Staff professionalism concerns. Here's some examples. The doctor entered the room without forming in and offered a pair of gloves. He took them and dropped them into the trash can. Finishing patient central line. The RN did not scrub the hub. I asked RN if I could help by getting the antiseptic. The RN responded, not needed, just let it ride. The APN asked the RN to go off protocol. The RN was concerned, mentioned the written order, did not include the off protocol interventions. The APN reported, I'm driving this treatment plan. So how we say some of these things and the tone that we use and visually how we portray it all can relate to not feeling safe and being disrespected. So here is a really interesting model that is being used in some of the hospitals and was developed by Ray and al. And it is called Promoting Professionalism Through Authoritative Guided Intervention. So I'm just going to spend a few minutes with this and explain it to you. What it says is that usually there's only 2 to 4% or 5% of people that, you know, behave unprofessional, okay, have unprofessional conduct. And what they found is that with those 2 to 4% people, if you use this process, that 75 to 80% will respond to this awareness pyramid. And what it does, it says, you know, when you first recognize that someone's being disrespectful, as long as it's not, you know, usually really bad, as long as it's not really egregious, and it's not harming somebody immediately, then you can use this process. If it is very harmful and very detrimental and it's violent or, you know, whatever, very extreme, then you know, avoid all these steps and you go straight to disciplinary intervention. So this process is used when you have a disrespectful behavior that's happening. For example, some of the examples I gave you, you may just take that person aside as a manager or as a peer and just have an informal, as they say, a cup of coffee or a cup of tea, and you talk about what had happened and why it might have happened and how you may support that person and coach that person to maybe change the way they are expressing themselves. Perhaps their intentions were good, but the way they communicated those intentions did not come out respectfully. So that's all it may take sometimes. Now, if the behavior continues and the person has not learned from it, then you would escalate and you would go to the first level where you're seeing there's an apparent pattern. And if it continues, where you've done some coaching, you've done some training, but it still continues, then you would go to a guided authority where the pattern proceeds, and then you would put some more stricter interventions in place. You may say, you know, a performance, a letter in their performance review, identifying this, identifying that you have provided training. You may say to them that they cannot be involved in certain projects because of that behavior. So it would be guided interventions that would happen in level 2. Now, if the behavior does not change at all after all your measures and your interventions and your support and your training and your education, then it would be disciplinary. And so what disciplinary would have to depend on your organization, what that would be for you. Is it a suspension? Is it, taking their license, depending on how severe it is, of course, right? So that would be the levels that you would go through this pyramid. And it's a very useful model to use because helping people to change their attitudes and how they talk and to be more respectful is very subtle. It's not an easy process, and we are always challenged with how to address that, especially when you have people in authority figures. So you have to ensure that throughout this process, especially when you go to levels 2, level 1, 2, and 3, that you document, you make it formal. You don't have it over a cup of coffee, but you change the environment, you have it in your office, you document it so the person knows that this is now very serious. So this is just a model that has been used. The literature that you received, there is the whole article on this and how to use it and how to implement it. So I would really encourage you to look at that. And what they found using this process is that, as I said, 78% of the people improved, and you did not have to go into the disciplinary area, which was great. And it's interesting that most of another programs showed that when they increased the people's respect and they addressed them, there was a correlation with this, a compliance of hand hygiene. There was an increase of hand hygiene. They noticed that that one impacted the other. And when you have increased hygiene, of course, then you have it correlates with low infection rates. So the culture of safety and the culture of respect have a huge impact, and just culture, as we talked about earlier. Addressing all those things within your organizations have a real impact on better interventions and better patient safety and reducing harm. So it's a combination of all three of those, not one by itself. So patient complaints and surgical outcomes, as I said, really improve when you have respect, trust, and team performance. Patient complaints. So when clear and effective communication is really important. When you look at staff concerns, you also want to look at patient complaints. For example, the doctor did a very poor job of communicating. He raced through an explanation of what we should expect, then left without giving us a chance to get clarification. Respectful. The doctor was rude to the patient. The doctor said, "Don't make my job more complicated." The doctor then received a page and said that it was regarding an important patient he needed to see. So we need to always add, these are the kinds of complaints that we get from patients. It's not always about the treatment or the right options that were given, but the way that we as health professionals communicate with our patients. And very important to have clear and effective communication so patients understand what you're trying to give them on what information on their drugs or the treatments, and that it's done in a respectful manner. So in summary, I promised that I would not take all your time and try to catch up on our timing here. So in summary, behaviors that undermine a culture of safety and respect interfere with the team's ability to achieve intended outcomes. They create an intimidating, hostile, and offensive, unsafe work environments and threaten safety and violate policies. Addressing these behaviors that undermine a culture of safety requires a plan focused on leadership, an intervention model, and good data. We must pursue good systems and professional accountability. And in the model of culture of safety, there are all these domains that we have, and it's one of the most important domains that we can address. And I think what you've heard all morning in regards to culture of safety, workforce safety that Sophia spoke about, the culture survey that helps to identify what is the perception of the culture of safety within our organizations, and some of the tools that we've gone through, identifying how you develop a just culture, looking at those 3 area risk behaviors that you see in our organizations on human error, at-risk behavior, and reckless behavior, and how to manage all 3 of them is very different for all 3. And also this model that we presented here today, promoting professionalism through authority-guided interventions, are all tools that I hope that you will go back to and look at and see how you can implement within your organizations that help to develop a culture of safety. And that's it for me then. We are finished. Thank you very much. I hope that this was useful and that you will have a lot of discussions when you get back to your organizations about creating a culture of safety. Thank you very much.
Thank you very much, Anita. Any question? If anything.
I think this is the end of the session. I wasn't sure if somebody was coming on, but I believe your next session is next week.
Yes.
That will happen on August the 25th
Yes.
at 8 o'clock as well. Is that correct?
Yes, you're correct.
No?
सोफिया से बात करिए. सोफिया से कनेक्ट नहीं कर सकते.
सोफिया कनेक्टेड है, हमने अपना माइक वर्क किया है.
Hello.
Yes.
Can we conclude the session?
Sorry?
Conclude the session now.
Sorry, dear. I can't understand what you're saying. Sorry.
We are done for today. Can we conclude the session? We are done for today.
Yes, we are done today. Yes, Anita has finished her session, correct?
Yeah.
Okay.
Okay, we will see you in the next week on 25th of August.
Yes. Yes.
Okay, thank you so much for delivering a wonderful session. Both of you.
Thank you, dear. Thank you for being on the other side for us.
Okay, thank you.
Thank you.